Good morning, good afternoon, good evening, colleagues, for joining us from all over the world. You're welcome to today's digital events titled From Pollutions to Solutions, Empowering Sustainable Pharmacies for Climate Health and Environmental Stewardship. So my name is Chima Amadi. I'm the FIP lead for DG21, which is Sustainability in Pharmacy. So I'll be moderating today's event. So thank you. We have some wonderful panelists, and we also have our wonderful FIP staff who is supporting us as well to make this event a success. Next slide, please. Right. So a little bit of housekeeping to let us know that this webinar is recorded and live streamed via YouTube. So people who are not able to join, or in case you would like to watch this webinar again, so you can always go to the YouTube and watch that. And the recordings of this webinar is also available on our www.events.fip.org, where you can see list of all the webinars and digital events that we've done. Then, based on as the webinar goes ahead, you can always ask questions with the question box. You drop your questions there, and then we'll pick it up and, of course, ask them to the appropriate speakers or panel members. And then also, you're also welcome to provide feedback to us in terms of how you found the webinar, was it useful, what you could improve, and that will we really appreciate your feedback. So thank you in advance. And also, if you're also interested to be a member of FIP, you see the link below where www.fip.org/membership, whereby you see you can be able to become a member either as a young pharmacist, as ECPG, and of course, if you also want to be like a full individual member, those options are there for you. Thank you. Next slide. Right. So, we also have translation features on Zoom in case of, because this webinar will be presented in English. So in case you want to translate to your language, so step one, as you see outlined here, you turn on the captions, you enable translation toggle as the step two, choose your preferred language under my captions language, and then you can follow along with live translated captions based on your selected language that you chose. Thank you. Right. So, as the moderator, so I'm introducing the webinar now. So we'll be hearing from wonderful speakers. So the first speaker after now will be Haley Blackburn, Associate Professor, University of Montana, United States. Her topic will be on air pollution, climate change, and at-risk populations. And our second speaker will be Vincent Breton, Director, Resource and Climate, United Switzerland. So his topic will be on sustainable practices and initiatives. Then our third speaker will be Tarek Hussein, Pharmacy Manager, Wella Pharmacy Canada. We'll be speaking on green prescribing and low carbon alternatives, sustainable pharmacy practice and advocacy. Then after our speakers have finished presenting or speaking, we'll have a moderated discussion with you, our beloved audience, based on your questions and your feedback in terms of your Q&A, drop questions and all. Then after that will be the closing and the next steps following this webinar. Next slide, please. Right. So we have three key learning objectives. The first one is we raise awareness of health impacts of air pollution and its links to climate change, especially in vulnerable population groups. Second one is we want you to highlight the environmental impact of pharmaceutical production and use, including emissions from manufacturing and inhaler devices. And finally, our objective is to empower pharmacists and healthcare professionals to adopt sustainable practices and advocate for climate-conscious healthcare. Next slide. Right, so this webinar or this digital event aligns with FIP's three key areas talking about environmental sustainability, economic sustainability, and social sustainability. But however, we'll be delving much more into the first area, which is the environmental sustainability. FIP, pharmacy sustainability, examines the intersection between each of these areas of pharmacy. You agree with me that both environment, economic, and social perspectives in sustainability, they're all intertwined and they all overlap across each other. So FIP ensures that we have a perfect or a near perfect overlap of these three key areas. Next slide, please. Right, so we go to our first speaker, Haley Blackburn, Associate Professor of Pharmacy Practice, Director of Education, LS Skaggs Institute of Health Innovation, University of Montana, Skaggs School of Pharmacy, United States. So Haley, over to you. Thank you very much.
Hi everyone, I'm Haley Blackburn. I'm an Associate Professor of Pharmacy Practice at the University of Montana Skaggs School of Pharmacy, and I'm also a founding member of RX for Climate, which is a global network of pharmacists working at the intersection of environmental sustainability, climate change, and human health. Today, I'll be speaking with you about air pollution, at-risk populations, and the role of the pharmacist in addressing this health issue. So why is air pollution so important for pharmacists to understand and to think about in our practice? Air pollution is a major global health concern, and a variety of sources estimate annual global mortality attributed to air pollution to be somewhere in between 7 to 8.8 million deaths annually, just a staggering number. The health harms and the massive disease burden attributed to air pollution has been consistently demonstrated in the literature, and air pollution is now widely recognized as a risk factor for the development of non-communicable disease. In terms of global risk factors for premature mortality, it's second only to hypertension. And although 99% of the world is exposed to PM 2.5 levels above the World Health Organization's air quality guidelines recommendations, the health impacts of air pollution are not distributed evenly around the world or even between populations. And so this makes air pollution a major issue in terms of global health equity. So what exactly do I mean when I say air pollution? As you saw on the last slide, we typically divide these up into indoor sources and outdoor sources, and we can break it down into other ways too. Outdoor pollution is associated with more global morbidity and mortality, and it comes from a variety of sources, including vehicles, power plants, industrial activities, waste incineration, wildfires, agriculture, and dust storms. Whereas indoor sources include pollution from cooking and heating, from tobacco smoke, and outdoor pollutants, which get into indoor spaces and then become indoor pollutants. So bottom line with all of this, with the sources of air pollution, most major sources of air pollution are caused by human activity. They involve burning fossil fuels or biomass, and the byproducts and particular pollutants that are coming from these processes are harmful to human health. These different sources of air pollution are comprised of different individual air pollutants within them, and so any type of air pollution might contain particulate matter broken down into different sizes of particulate matter based on how coarse or how fine it is. Ozone, sulfur dioxide, nitrogen oxides, carbon monoxide, volatile organic compounds, and more. So typically when we talk about air pollution generally, it contains a lot of these different things. However, some things we know are more harmful than others or more associated with certain health impacts than others. So airborne particulate matter, particularly fine particulate matter, or PM 2.5, which means that these are particles that are less than 2.5 microns in diameter, which if you look at this diagram here, that is less than 30 times smaller than the diameter of a human hair. Very, 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 very small. These fine particulate matter can ultimately end up penetrating deep into the lungs, and not only deep into the lungs, but also can actually cross the barrier at the alveoli into the bloodstream. And those smaller particles are associated with greater harm because they get into the circulation and are associated with systemic effects beyond the lungs. So these have been highlighted in recent literature as being particularly problematic for human health for a lot of different reasons, but we'll see in later discussion here how these health effects extend beyond the lungs. So as we think about these sources and types of air pollution, it's important to also recognize how closely they're tied to climate change. The same fossil fuel combustion that drives climate change also produces pollutants that harm our health. The figure on this slide shows air pollution deaths attributed to fossil fuel use, and I've seen other global studies that suggest we might have over 8 million deaths annually just attributed to the air pollution from fossil fuel combustion. So massive disease burden, and we know that climate change itself worsens air quality by increasing the frequency and severity of wildfires, by lengthening pollen seasons and driving more dust storms and heat waves. So in other words, the challenges of air pollution and climate change are completely interlinked, and we need to think about tackling them together as these interrelated health challenges. It's also important to remember that science tells us there's not a safe level of air pollution exposure for anyone, and that ideally we're avoiding exposure altogether. The severity of impact and the proportion of people affected by exposure to air pollution is going to depend on a number of different factors, but we can kind of think of this as a pyramid where the less frequent but more severe impacts at the top, like premature morbidity and mortality, ED visits, they're up there. They represent the less common but the more severe things, whereas the more common, less severe, or even subclinical effects are at the bottom. So many people are exposed to air pollution and may not initially show overt symptoms or have serious health issues arise in the short term, but this does not mean that no harm is occurring when otherwise healthy individuals are exposed to air pollution. Evidence shows that the health impacts extend far beyond the lungs. So we can see here a long list of systemic effects. So it's much more than respiratory conditions that are impacted by exposure to air pollution. Often we think or we see that exposure to air pollution, there's an underappreciated risk for cardiovascular issues, including all-cause cardiovascular stroke mortality, ED visits due to cardiovascular disease, hypertension, arrhythmias. We also see harmful outcomes associated with exposure during pregnancy, so maternal and infant health, including premature birth, low birth weight, preeclampsia, and then other impacts as well, cognitive impacts, mental health impacts, even increased risk of poor glycemic control with exposure to air pollution. So this long list here of both short-term effects and long-term effects is not designed to be comprehensive by any means. There are new things we're learning every day, but the point here is that this impacts nearly every system in some way or another, and we really need to be thinking about air pollution as a risk factor more broadly. Our populations of greatest concern when it comes to air pollution are listed here on the left, and you can see that risk changes across the lifespan with changing health status and with other sociodemographic factors. So ultimately, the risk of harm is influenced by the hazard itself, in this case, the type and source of air pollutants, the dose or the amount and duration of exposure. It's probably pretty intuitive for an audience of pharmacists, and then the vulnerability or the susceptibility of an individual or a population. So in this case, vulnerability being things like the location of work or home, especially if it's close to traffic or an industrial area or other geography that might result in increased air pollution, or maybe it's housing quality, other living conditions, the type of occupation, or socioeconomic status more generally. And then susceptibility, everything from age to life stage, pregnancy, pre-existing conditions, or even genetic factors will influence outcomes overall for these at-risk populations. So what can pharmacists do? I think that there are a lot of opportunities if we think back to that last slide and which factors might be modifiable or how we might benefit by being proactive in addressing concerns in our most at-risk populations. But I think I'm going to just divide my suggestions up into three broad categories that capture some of the greatest strengths of our profession. So first, pharmacists as public health educators. Second, pharmacists as clinicians. And third, pharmacists as advocates and trusted community members. So I'll take a moment to tell you a bit about my own work as some examples of actions pharmacists could take. I'm coming to you for this presentation from Montana in the United States. It's that purple star there on the upper part of the map. And in Montana and much of the western United States, wildfires and wildfire smoke have become more frequent and more severe over recent decades. In many areas where we saw progress toward cleaner air over decades with increasing EPA regulations, reductions in emissions from industrial sources, we're now seeing this pollution replaced by wildfire smoke. So this health threat is in the minds of many in my region, and this is an area I've chosen to focus some of my efforts to get pharmacists more engaged in environmentally sustainable and climate resilient health systems and communities. And it turns out actually that wildfire smoke is not just a western U.S. population, and that smoke can be transported for thousands of miles, as shown by this NASA satellite image here, with California sending their smoke up north to Montana and even into Canada. And even more recently, as shown in this picture here on the right, some of our major cities like New York City have seen major wildfire smoke events from wildfires burning hundreds or thousands of miles away, and the smoke being carried, exposing millions of people. A study just published just this last week in Nature attributed over 41,000 excess deaths annually due to wildfire smoke exposure in the United States, with those numbers projected to grow under business as usual climate scenarios. So air pollution and wildfire smoke are becoming an increasingly urgent public health problem for us. So given pharmacists' accessibility and their frequent patient contact, I've been engaging with pharmacists in our state and in our region to better understand pharmacists' knowledge, perceptions, and behaviors related to wildfire smoke and to other climate-related hazards, to inform projects and programs to support greater engagement with these topics, greater involvement in broader efforts to reduce health harms associated with smoke exposure. In general, both anecdotally and in the data I've collected, I see general themes. Pharmacists are concerned, they think it's important, they'd like to do something in their professional roles. And these are data from just one recent survey, and I'll call out just a few things in the responses I received. So first, in the upper left, you can see that pharmacists report very infrequent counseling on topics related to wildfire smoke, from discussing health risks to actually proactively getting an action plan in place for those with underlying respiratory conditions, like an asthma action plan with the air quality data integrated into it. In fact, approximately half or more said they never talked to patients about these topics. And while they viewed these topics as important and wanted to do more, they said the biggest barriers were that they didn't know enough, over a third, or they said patients don't really ask or they don't seem interested in this. But in good news, there was interest in engaging in more education, becoming more involved in public health efforts. So really, pharmacists are open, they want to do more, they just seemingly, from at least these data, just don't know enough, don't feel like they have good tools or pathways forward, and that maybe that engagement with patients feels a little bit difficult around these topics. So some of these data have informed more recent efforts to get pharmacist education out to our network of pharmacists. These educational support tools include patient handouts, brief educational readings, and presentations for pharmacists and pharmacy staff to help increase awareness, equip them with tools to have more patient conversations, or at least have informational posters or handouts in their pharmacies with useful information that maybe can be passively absorbed by patients visiting a pharmacy. Additionally, pharmacy students have worked with me on community outreach efforts and partnerships with local pharmacies to distribute air filters to at-risk patients during wildfire smoke events. And these students have become more involved with research in this area as well. You can see a couple of these students pictured on the right. I'm really proud of their engagement. In my experience, students have been some of the best champions of this work. They're concerned about pollution and climate-related issues, and they're eager for pathways to do something about it. So those prior projects are good examples of maybe a public health education campaign type approach you could take as a pharmacist to really get out there and increase patient awareness. But what about in a clinical setting? Maybe that pharmacist as a clinician role. Well, I think we can start identifying at-risk patients and patient encounters, really thinking about air pollution as an environmental driver of health, and then looking at susceptibility and vulnerability of patients with modifiable risk factors. Are there ways that we can educate patients to monitor air quality more, to come up with air quality action plans in the same way we might do an asthma action plan for somebody with asthma, or an action plan for somebody with COPD? And then what can we do to help them figure out how they could reduce their risk of exposure and really individualize that plan, to talk them through different strategies that are effective and to help them understand how air pollution ultimately impacts their health. And then we can also think about engaging in population health approaches to address air pollution risk. There are even ICD-10 and ICD-11 codes that go along with air pollution exposure. But the other thing we can think about is just who are our patients that are at greatest risk, and how might we engage with things like specific education campaigns, pushing out EHR-based alerts for people who are at most risk when air quality is poor, those types of things. On the right-hand side here, this screenshot is just an American Heart Association clinical screening tool for air pollution risk, as one example of a way you might start integrating this into patient intake, patient assessment, the questions you might ask to understand the different types of exposures and risks that a patient might have on an individual basis. Finally, regarding our role as advocates, reducing emissions is the single most important step we can take to lessen the health burdens of air pollution. So I'll just call back to this earlier slide looking at air pollution deaths from fossil fuels. Unlike individual interventions, pollution reduction strategies through these reduction of fossil fuel emissions are more cost effective, they're more equitable, and they bring almost immediate health benefits by cleaning our air. Cleaner air the moment the fossil fuel use declines. And the bonus, these same actions are going to cut greenhouse gas emissions, and they're going to slow climate change. So these two are inseparable. Climate change fuels more wildfires, more dust storms, more events that impact air quality. And if we can take this step, we potentially can reduce this dual threat. My call to action is this: talk about it. Use your role as pharmacists, clinicians, educators, trusted voices in the health community to advocate for policies that move us beyond fossil fuels and toward clean, breathable air for everyone. This can be in your community, this can be in your health system, this can be in your country or on a global level. Just use your voice and let's move toward a better future overall. If you're interested in topics related to air pollution, you want to increase your knowledge or just find better resources and data, these are some really great resources I can recommend here on this slide, including the World Health Organization training for health workers on air pollution. It's a really great training toolkit. Lots of other great resources there for you to check out as well. Thank you so much for listening today. Unfortunately, I'm not able to be there live, but here's my contact information. Please feel free to reach out if you have any questions, if you'd like to connect to learn more, potentially collaborate on a project. Reach out via email. I'd be happy to connect with you. And again, thanks so much.
Thank you so much, Haley, for that wonderful presentation. Right, it was quite inspiring. Please, like I mentioned earlier, be happy for you to drop your questions you might have regarding every session. Then we'll collate them all and we can answer that during the Q&A session. Right, so moving on to our next speaker, Vincent Breton, Director, Results and Climate, United, Switzerland. Vincent, you have the floor. Thank you.
Thank you so much, Shima, and thank you so much to FIP for the invitation to participate to this webinar. So I'm Vincent Breton from United, and next slide, please. I'll do a brief introduction of United. So I'm based in an organization which is an international organization hosted by the World Health Organization here in Geneva, and that is working on access to innovations, medical innovation in the global south, so in low and middle income countries. And we are working on medicines, we are working on diagnostics and other health products and making sure that they are accessible equitably everywhere in the world. And that's applied in HIV, tuberculosis, malaria, women's health, and pandemic response as well. And I'm going to talk today about some of the lessons we've learned looking at our work through the lens of climate change. And if you move to the next slide, when we developed a climate and health strategy a few years ago, we figured that in order to properly embed climate in our reflections, we need to consider several dimensions. In addition to the usual dimensions we would look at for any kind of health innovation. Because normally we would look at making sure that we have the right products, that is of good quality, affordable, in the right supply, that there is demand for it. But when you start looking from a climate standpoint, you realize there's more dimensions to consider. One is making sure that the products are not harmful, that the production of those products and the entire supply chain of those products doesn't generate greenhouse gas emissions more than needed or an environmental footprint more than needed. Secondly, that those products are resilient and also part of supply chains that are resilient to climate change. And I will come back to those two dimensions in the rest of the presentation. But I want also to flag there's more dimensions to it. And from an adaptation standpoint, we're also looking at ways in which medical treatments, for instance, can be a response for communities that are impacted by climate change. If you think about vector-borne disease, for instance, that we know are sensitive to climate change. But I will focus today mostly on the footprint of health products, in particular from a carbon standpoint, and a little bit about the resilience of health products. So next slide. And here, this is an overview of a study we've conducted also 2 years ago called Milligrams to Megatons, and the reference will be provided later in the presentation, where we looked at 10 key products in our portfolio. So we had 5 medicines, and I'll speak a bit more about those in a second, but also a number of diagnostics, for instance. And for all of those products, we look at their entire supply chain. So from the very beginning of acquiring raw material to manufacturing those products, bringing them to the places of use, having them used, and then finally the waste management. And for all those products, all those supply chains, we ask ourselves 3 questions. One is, what are the global greenhouse gas emissions associated to all these activities for all these products on a global scale? Secondly, what's the broader environmental footprint when you think about water pollution, air pollution? We just heard about air pollution before, and other forms of pollution. And finally, the reverse question, do we see risk of vulnerabilities because of climate change on those supply chains? And you see here the summary outcome of this work, which shows, first of all, in terms of emissions and footprints, that the main phases of this value chain, where we see strong hotspots in terms of emissions, are material acquisition and production. So this is where, when it comes to greenhouse gas emissions, when it comes to environmental footprint, we see the biggest in our study. And then you see risk themselves being either at the same stage of early stage production, where climate could have an impact on the manufacturing site, for instance, but also in last mile transportation and at the point of use. On the next slide, I'm going to double click on carbon emissions. So those are the same 10 products. Here you see with more detail. And this is the overall emissions that we estimated in our study for each of those products, again, on the global scale. And you see also the breakdown between the different steps of the value chain. One key message here is, first of all, the footprint of health products is highly dependent of the products you look at. So you can see on the right-hand side that the emissions of different product classes can differ widely, sometimes, factor of 10, 100, 1,000. And that's due to the products themselves, but also, of course, the scale of their use globally, whether it's used by millions, tens of millions, hundreds of millions of patients. Secondly, you see that the breakdown of emissions is actually very clearly oriented towards material and manufacturing. For all the medicines we studied, with one exception, you have most of the emissions coming from either the acquisition of raw material, and so therefore the emissions associated to the production of all the raw materials that go into a medicine, or the manufacturing itself. And that's very important because oftentimes when we talk to partners, colleagues, and so on, people have in mind that transportation of medicine might be a big contributor, for instance. And our study shows that it's not a big contributor, especially if transportation is done by sea. When it's done by air, it can be more important, up to 20%. Next slide. And here I'm zooming on the HIV treatment, which was the biggest footprint in our study, corresponding to 2.6 million tons or megatons. And of course, you may wonder, is it a lot, 2.6 million tons? I don't think many of us use tons of CO2 on a daily basis as language. And so you see here a logarithmic scale, starting from 1,000 tons up to the left to 10,000 million tons to the right. So essentially the footprint of a few people living in Europe on the left, and you multiply by 10 at every box when you move to the right, and you end up with the more or less the worldwide emissions, which are 40,000 million tons. So 2.6 million tons is somewhere in the middle of this scale. And you see a picture here of at the bottom of the slide of Geneva. This is the city where I am based and I work. And actually the annual emissions of Geneva as a city are exactly 2.6 million tons. So one treatment, HIV treatment worldwide, corresponds to emissions equivalent to one city, which is a mid-sized city like Geneva. And this is why we call our report milligrams to megatons, because this is a treatment that involves 650 milligrams of active ingredient for a daily treatment. But overall, on an annual basis, at a global scale, results in more than 2 million tons of emissions. The good news, and I'll move to next slide, is that there are ways to decarbonize a treatment like this one. So I'm still focusing on the same example, HIV treatment, which is TLD regimen. And in our study, we've looked at what are the solutions available to reduce the emissions. And this is kind of a complex graphic, but I'll take a bit of time to explain how it's built. When you move from left to right, you see all the potential solutions stacking up to remove up to 100% of the carbon emissions from this supply chain. And when you look at the vertical axis, you see how much it would cost us to decarbonize. When it's a negative cost, it means actually that you can decarbonize and reduce the cost of production. An example of that is if you can improve the efficiency of your process. You can obviously make some savings on the manufacturing costs, but also reduce the emissions. So those are typically the first types of solutions that we see in this graphic. And then you progressively get into other technological solutions that require extra investments. So you have an abatement cost that is positive, and you need to get to some of those solutions in order to fully decarbonize a product like this one. Part of the good news here is that you can go up to 40 or 50% without increasing the cost of production. So for an organization like us focused on equitable access, focused on affordability for all populations in the world, it's very important to decarbonize, but do it without impacting equitable access. And we believe this is feasible based on this type of analysis. Next slide. Just wanted to show you a very concrete example of some of those solutions, and some of you may be familiar. It's called green chemistry or green manufacturing. And it's a set of 12 principles that can be used to optimize the chemical process of active pharmaceutical ingredient manufacturing, which is where most of the emissions are. And I'm not going to describe those in any detail, but just to say that it's part of a common practice in the pharmaceutical industry in manufacturing to start embedding those principles of green chemistry, and they bring benefits from a sustainability standpoint, but also from an efficiency standpoint and a cost effectiveness standpoint. Next slide. I also wanted to flag that, as pharmacists in particular, this is, I think, pretty relevant for you. To decarbonize healthcare systems, one thing is to decarbonize the treatments that we use that represent a significant portion of health system footprint. But another one is also to make product choices and use innovation to reduce emissions. And still looking at the same product, HIV treatments, we've done one analysis, which was to look at actually the previous generation of HIV treatment, which was efavirenz-based. And we realized that the treatment used 10 years ago, efavirenz, was actually much higher footprint compared to dolutegravir, which is the new treatment that we supported as an organization in terms of introduction. And so we calculated what would the emissions look like if we had kept the old treatment, efavirenz. And you see that's the top part of the curve here. And with DTG as the main treatment, you see the middle curve, a very significant reduction of worldwide emissions associated to HIV treatment. We estimate that the difference between those two curves over 10 years is 26 million tons of carbon emissions that have been avoided. It's quite interesting because obviously we haven't done this transition from efavirenz-based to dolutegravir for environmental reasons. We have done it because DTG is a much better treatment. It's a safer treatment, it's more efficacious, and it's also a more affordable treatment. So there was plenty of reasons to shift to this new generation of HIV treatment. What we're seeing here is that there was actually one reason that we were not aware of at the point of transition, but that was also a very powerful reason to make the transition. It is that it's a much lower carbon footprint than the predecessor treatment. Let me now switch to the next slide, and I'm going to talk about another aspect of the intersection between climate change and health product supply chains. And that relates to the resilience of supply chains and of products themselves to climate risk. I'm taking here an example of malaria, and specifically malaria treatment, ACTs, so artemisinin combination therapies, that are used as the primary treatment by hundreds of millions of people every year, especially in Africa, but not only in Africa. And this slide depicts in a very simplistic way the journey of a treatment like this one. It starts in China because one of the active ingredients of ACTs is based on a plant that is cultivated called artemisinin, and the cultivation happens to be mostly in China. The journey continues in India, where most of the manufacturing happens, and this is one example of a manufacturing site, and then continues into countries like Nigeria, and just taking that as an example, where the product will arrive in the central warehouse, be dispatched to health facilities, and then be provided to patients. All along this journey, if you look at it from a climate standpoint, there's a number of risks. First of all, the active ingredient in China is a plant. It's sensitive to climatic conditions, and actually it's been shown over the last 15 years that the years where there is a particular climate, in particular a very dry and hot climate in those regions of China, the quantity of ingredient that can be extracted from the plant decreases by 30 to 40%. So a bad year means potentially a risk on supply at the very beginning of this supply chain. We know also that 3/4 of the sites, manufacturing sites in India, are concentrated in very few regions that are themselves prone to potential flooding. So unfortunately, there is a risk there. And if one of those regions was to experience a flood, we might see a disruption of supply. And finally, this is a product that has been shown in the past to have demonstrated sensitivity to storage conditions. If it's stored in a place where the temperature is too high, for instance, it could degrade. And as you can imagine, with consequences on the quality of the product and the ability of the treatment to be effective. So this leads me to my last slide, if you move to the next one, which is about heat stability of products. And I'm sure this is a topic that you are very familiar with as pharmacists. But what I want to encourage you to do and encourage all of us to do is to look at it through the lens of climate change. We already know that in many parts of the world, drugs and diagnostics cannot be kept in the standard temperature range during their transportation or during their use. For instance, if they're kept at someone's home and the temperature cannot be kept at 30 degrees, for instance. That is only going to grow as a problem. We know that heat waves are going to increase as a result of climate change. We know that humidity conditions are also becoming more challenging in many parts of the world. And therefore, the question is there a risk that the products that we rely on for very basic healthcare in every part of the world start to become less effective because they're exposed more and more to those extreme conditions? And based on the work we've done, and we've consulted many experts over the last few months at United, I don't think we have a clear answer to those questions. There's many evidence gaps of really testing the products in the real conditions that they are facing, anticipating also what those conditions would look like in 5 years, in 10 years, in 20 years from now, when climate change is going to have more and more impact in terms of heat waves and humidity conditions. I think I will leave it at that, with on one side some reflections on mitigation and what pharmacists as a key player, key stakeholder in supply chains, can do. And on the side, the question of resilience, adaptation, which is also very central to the work of pharmacists and which I hope we can take forward as a priority. And here, a few references to our publications if you want to learn more. Thank you so much for your attention and looking forward to the discussion.
Thank you so much, Vincent. That was quite insightful. Thank you so much. That was really great. Right. Next speaker will be Tarek Hussein, Director of Content, the Canadian Association of Pharmacy for the Environment. Tarek, you have the floor now. Thank you.
Thank you, Shima, and good morning, good afternoon, good evening, everybody. And I'm first, I would like to thank FIB for inviting me today. It's very exciting to be here and very exciting to be with Haley and Vincent, who make my job probably much easier because they laid the foundation of some of the stuff I'm going to talk about today. My talk is about climate smart pharmacy, a call to action for sustainable practice and advocacy. And I wear so many hats. So I'm a community pharmacist in Canada. I also work in a hospital setting in Canada as well, in Ontario. And at the same time, I volunteer in several organizations, one of them that I'm representing today, which is the Canadian Association of Pharmacy for the Environment, or CAPHE. And I'm very excited to share some of the work that we do at CAPHE. And I hope that this inspires most of you to do similar work. So today we're going to talk about the planet and the patient, our planet and our patient. And I'm glad that, as I said, Haley and Vincent laid some foundation. So the talk I'm going to make for you today, or the plead, is going to make much more sense. So if you are not yet sure, here is a statement. It's a fact. The climate crisis is a health crisis, and it's by the WHO, the World Health Organization. You can feel it in the work already. Smoke days, driving inhalers refills, heat waves, pushing cardiac events, infections shifting with the seasons, and there's a lot of anxiety, a lot of tension about that. And it's not so far from us. It's about our patients and our practice. When air quality drops, asthma and COPD flares. When temperatures spike, we have dehydration, arrhythmias, and heat stroke. Heavy rains causes GI illnesses. Poor harvests, as Vincent mentioned, can stress nutrition, but also affect medication production. And it's unfortunately, as Haley said, it is unequal. There's inequality because children, older adults, people with lung and heart disease, low-income communities are the communities that are affected the first and hardest. So for us right now, for pharmacy, the message is simple. Climate is now a clinical determinant. It changes who walks through our doors to pharmacies and hospitals, what they need from us, and how reliably we can deliver care to them. Our professional codes requires us to serve the wider community. So we always talk about, the patients, their advocates, their families, the community, the other professionals, everybody. And in a climate era, I can debate with you that this explicitly should include planetary health, because environmental conditions now act like a foundational determinant of health. So sustainable pharmacy isn't a side project. It's part of our profession and professional judgment every day. When we prevent waste, choose low impact options, and prepare for disruptions, we are fulfilling our ethical duties. The rest of this bulk translates the duty into practice and everyday actions. So let me take you in a quick, high-level view. You know that, I don't know if you know, but the healthcare emissions are about, our footprint is about 4.4, represents 4.4 of the global emissions. It's higher than the airline industry. And 71% of that comes from supply chain. And I think Vincent gave us a couple of interesting examples about supply chain, especially transportation, packaging, logistics, all that stuff. So it's very important to so production, packaging, transportation are very key. And the top 10 emitters in the world are basically representing more than 75% of emissions. So most of them are the high emitting, as you can see on the list here. They are the higher emitters. And what does this tell us with all the information I think Haley and Vincent also shared is that we need environmental literacy. We need to understand what does this mean, what kind of claims that the companies are giving us. So if you are in a purchasing position or you are a pharmacist, you need to understand what exactly the emissions happening, where they are happening, the life cycle, the different scopes, and all that stuff to be able to have a more informed decision on how to cut carbon, but also to reduce the impact, the footprint of healthcare emissions. And if we look at pharmacy particularly, the most significant impact comes from medications. And I appreciate also, again, Vince, all the examples you shared, because this is making my life easy. But I'll share with you this slide, which is information from the NHS in the United England, in the UK. And it shows that pharmaceuticals contributes to 25% of the United Kingdom healthcare emissions. That is the highest contribution, actually, if you put at the chart I'm sharing. And this is our Pareto, if you know the Pareto rule. So this is our portion. And inside this, there are two portions. All the pharmaceuticals are 20%, and 5% of that only for anesthesia gases and metered dose inhalers. So 5% of the whole healthcare emissions are coming from two major areas, the anesthesia gases and metered dose inhalers. And the global pharmaceutical industry emissions intensity which is shows the impact on the environment compared to other industries is 55% higher than the automotive industry. So you can see healthcare is big and large in emissions, and we really need to work as pharmacists in helping with that. I'm going to give you a little example in a coming couple of slides about methadose inhalers and the work we're doing to reduce that. So it's important to keep that in mind. So the two buckets that we use in addressing climate change in pharmacies and in manufacturing and everything is two main areas: the mitigation, which is reducing emissions from therapeutics and operations; the prescribing, lower impact choices, efficient workflows, less waste; and the adaptation piece, which is protecting patients and services from the climate impact. Heat smoke plans and having disruption plans. We'll talk about it also in detail. Okay, so the two pillars that I'm going to share with you today for sustainable practice, whether you're in a community or also you're in a hospital, first one is the medication optimization, and it's a mitigation strategy. And basically, we are trying to reduce the environmental impact of therapeutics without compromising therapeutic outcomes. And typical example is what Vincent shared about the HIV treatment. That's a typical example of doing that. But I'm going to focus more on, as a clinicians, what we can do. So the greenest drug is the one that not yet taken, that the one you have not taken. So keep that in mind all the time. So the different strategies that we're going to share today, as you probably all know, is deprescribing, okay, which is basically targeting polypharmacy, low value repeats. Like, for example, I'll give you a typical example. I'm going to focus also on inhalers. There's so many inhalers like salbutamol is prescribed when people have chronic cough and they go to or acute cough, and they go to the hospital or an emerge, and the doctor say okay, because they cannot breathe a little bit, so they give them the inhaler. This is definitely something that can be stopped right away after the patient gets better. But how many of you has seen this keep going and going and going? This is one thing. The next thing is medication adherence. We are the experts as pharmacists in making sure that we put strategies and interventions and practices to kind of make sure that the patient take their medication properly. They take it the right way, like techniques, for example, for inhalers. Take it correctly, take the right dose, take it consistently as prescribed. So this is another thing. It's simple, but it is very big. Therapeutic interchange, and this is something I'm going to focus as well in the coming couple of slides about substituting medication with the therapeutically equivalent options that are more greener. And we'll talk about switching methadose inhalers to other greener options in a second. And the final thing is restricting the use. And there are so many medications that have high impact, and we can do that. Like, for example, phasing out the dysfluorine anesthesia gas. If you are working in a hospital and you can work with anesthesiology and the management team to do that. So this is basically restricting the use of it only when it is really needed, and then switch to much more less impact inhalers. Sorry, I mean anesthesia gases. So here's a big study or the big case, which is the inhaler switch. And I think, I'm not sure if you heard about this, but this is big talk about it. It's in all the guidelines, including the GINA guideline, the Canadian Thoracic Society guidelines. I'm pretty much sure the American guidelines as well. And I'm sure in Europe, most of you have it. So there is a lot of statements to endorse switching the methadose inhalers that has the hydrofluorocarbon inhalers, because those ones, the impact of them for one inhaler lifetime use is as if somebody have drove the car, the same emission or the same footprint of driving a car for 170 kilometers. But when you switch then from MDI to DPI, you pretty much reduce that to almost 20% of that, which is around between 20 and 30 kilometers. So there are several wins of doing that on the environment, clinically and economically. One of the things we have done at the Canadian Association of Pharmacy for the Environment is we teamed up, or we participated with on something called the Climate Health Organizing Fellowship Program at Harvard, and we are advocating and organizing Ontario pharmacists to put some gentle pressure on our government here in Ontario to improve access to DPIs and allowing a smoother switch from metered dose inhalers to dry powder inhalers. So the second pillar is the sustainable and resilient operations. I'm sure that this makes so much sense for you. We're focusing here on operations, so mitigation and adaptation. So pharmacy operations, definitely paperless technologies, energy efficient infrastructure. I'm sure most of you have seen that. Recycling, talking about proper disposal of waste, expired medication, and also we have lots of take back programs in some countries that the patient can bring back their expired medication or unused medication, and also sharps that they use, needles for diabetes, for example, and how can we dispose that properly. Also sustainable procurement, and again Vince went into details on that, so I'm going to just leave a couple of things like bulk purchases for the high moving items, making sure that monitor inventory regularly to minimize overstocking and hence expiry, so you have to dispose that. The single-use plastic and plastic use in general is a big issue, and we always need to target that. So that is the operations piece, but also we need to make sure that we also have plans in place when disaster happens. Disaster planning, health heat impacts. Vince mentioned about the heat-related conditions and how can we make sure that medications are kept safe. Insulins when we have power outages. Patients who live in areas where they don't have fridges, for example. How can we make sure that happen when there are floods or fire? The pharmacy is not operating, or the hospital is operating in low capacity. Access to patient files, access to medications. We need to have those things in place before issues happen. Give you an example. When you go to a plane, you're flying. I just was flying yesterday. They tell you look at the exit, so you know where the exit is before. If anything happened, you don't need to look at where is the exit. You need to know what are your plans, so if things happen, you can act on it. And hopefully we can go beyond that and basically move upstream by focusing on social prescribing or addressing social determinants of health, because 50% of health needs are life needs, are social determinants of health. And if we address those, we definitely can address the underlying causes of the problems we see on daily basis. So social prescribing, if you don't know the terminology, is the formal pathway to connect patients with non-medical community-based supports. And I'll give you a simple example. Molds. If you have a patient who's living in a house that has molds, they will always come to you with respiratory illness. They will use inhalers, they will use steroids, they will use antibiotics, and they keep coming every month, they keep coming every 2 weeks with flare-ups. If we don't address the molds, if we don't remove the molds from their home, this will keep happening. So this is a typical example of how to address something that is not in our domain. It's not a pharmacy related, it's a social related issue, or housing related, or financially related, and make sure that this is happening. Now the further deep diving into that is green social prescribing. We are in a world that is full of, as you can see, I'm not gonna I don't need to add to what's happening to the world, but it's time to maybe people have a lot of anxiety, depression, they are worried. So connecting patients with nature-based activities like community garden, nature walks, going on a hike, doing yoga in the nature, all these activities reduces the stress, and also it creates connection. And connection is one of the things that we are missing in our world, and it is affecting the loneliness and social isolation. And we have done a lot of work, and I'm going to mention in the next slide, which is basically the paper we have published a very interesting paper about social prescribing in pharmacies in the Canadian Pharmacist Journal. You can scan the QR code, and this is the work that I'm very proud to work with the a very passionate group from the International Social Prescribing Pharmacy Association about this work. And also one of our colleagues is in Australia, Jenny. She is also an expert in how to train pharmacists in social isolation and loneliness. So it's a big area. We are also submitted for publication a bigger expert opinion paper about why pharmacy is important in identifying social determinants of health and social prescribing and reducing social isolation and loneliness. So keep an eye on that. And I'm going to leave you today with a call to action, with I call it the pharmacists 3 E's. Okay. So the first one is explore. So take 15 to 20 minutes after this call. This is a call for you. 15, 20 minutes mapping around you, looking around, see what you can do, and then evaluate, identify what you already do, and make some plans. For example, who are the patients on salbutamol that you can deprescribe or make sure they use it appropriately or switch, and then engage. So be a role model and engage with one person. I encourage you to engage with one person after this talk in the coming 2 weeks, whether it's a patient or a colleague, and talk about environmental sustainability. So I'm just going to quickly conclude by saying that the health of our planet and patient are linked. Pharmacists, we have ethical duty to a clear path to act, and we can deconstruct the footprint by optimizing medication use, building resilient operations, and championing innovative models such as social prescribing. And the journey starts with one step. I hope this talk motivates you to do one action. And I'm leaving 2 resources here for you. One is a resource page at the Canadian Association of Pharmacy for the Environment, and also our Canadian Pharmacists Association have an excellent resource page, including lots of talks about environmental sustainability. And thank you so much. I'm going to stop here.
Thank you so much, Tarek. That was quite very much great presentation and quite insightful as well. Really, really great. Thank you so much for that. Right. So I think we've come to the Q&A session. So that's Tarek and Vincent. Sorry, 1 second. 1 second. Sorry about that. I had a knock at the door. Right. So thank you very much, Tarek and Vincent, for that. So we'll go into the Q&A session. So we have a couple of questions here. So we can start with that and then we'll see. Right.
Question number 2 about
yes,
collaboration with
sure.
other providers. So this is something we're doing actually on daily basis. So thanks, Jeffrey, for the question. So I give you an example. I co-chair something called the Sustainable Prescribing Working Group, which is part of the Canadian Coalition for Green Healthcare, and I'm co-chairing it with a very, very big advocate physician, a family doctor and a hospital doctor as well. And among this group, we have lots of nurses, physicians, pharmacists, and other healthcare providers who are working in this environment. And we talk about how can we help each other. One example is we had a medicine doctor. She's a respiratory medicine doctor in one of the hospitals. She was doing a study on switching inhalers on bedside consultation by a pharmacist. So she's a physician, and the pharmacist was working on when patients are admitted with MDIs, they do a consultation at bedside and do this and see if they are eligible for switching to a DPI, which is the dry powder inhaler, and use the combination, by the way, of the steroid and a LABA, long-acting beta agonist, to be able to, they call it the smart inhaler right now, to use it for both control and rescue. And we have been helping them to publish the data, which is very interesting, actually, that they found that when they do that with the consultation of a pharmacist, so the physician is working with the pharmacist to activate the switch, patients are better controlled and they stay longer on the treatment after 6 months and 1 year follow-up. So that's just a typical example of how can work together as a healthcare providers.
And if I may add to this, to
Sure,
response to this question, I think it's a great question because what we're looking at is a transformation of the health sector overall, and this cannot happen without all the stakeholders. So yes, it's not just a question for pharmacists or for regulators or for industry. I think it's all of those stakeholders that need to come together, align on objectives, standards, and then drive that transformation of moving to better practices, better products. Insist on standards in particular, because right now, there's not one single way to calculate the carbon footprint of a product. And so if you were to ask, as you buy a product, different manufacturers to tell you what's the carbon footprint of the product you're selling me, you might get a different answer because of methodology. And that's one of the pieces of work that I know is ongoing by some experts and institutions to build those standards and make sure that we can have a comparison of products in such procurement processes.
Right. Thank you so much, Vincent and Tarek. Very insightful. So I think the next question here is, what awareness initiatives can be taken to stop the use of inhalers, anesthesia, gases, and to promote the use of greener alternative drugs?
I can start. So
Right.
the point is we don't want to stop. So that just to keep this in your mind, we just want to make a kind of a informed decision making. So some patients, for example, will still need to use MDIs. For example, when we talk about severe COPD, patients cannot use dry powder inhaler easily because it requires forceful kind of suction of the powder, right? So in this case, you have to use the MDI. But what we're trying to say is appropriate use, always, okay? Appropriate use of medication. So assess the patient and make sure, is it the appropriate treatment? As I said, is it a cough or asthma or COPD? If it's a cough, do we need to use that one? So you can deprescribe and stop it. Is the patient using the product properly? I saw so many cases in my practice where patient is using the inhaler completely wrong. And once we just educate the patient on how to use the inhaler properly, it works better, right? And the third thing is now, if the patient is eligible for a switch to a greener alternative, then we do that. So we don't want to just be kind of jumping right into the switch or stopping before taking the kind of mindset of kind of stepwise approach to manage that situation. So that is the point. I think lots of guidelines are available, lots of resources. And to Vince's point about the previous question is, I think we all work a little bit sometimes in silos, and I think we need to really come together if we are interested in this area and see what is everybody doing, and then we can just collaborate and complement each other instead of trying to reinvent the wheel while others are doing already a good job in some areas.
Thank you so much, Tarek. Vincent, do you want to add anything to that?
Sure, maybe two things. One is, first of all, the awareness about the footprint. I think Tarek was showing great examples of, if all the users, the pharmacists, but even patients are made aware that, you have those two options, and, they may be comparable from a therapeutic standpoint, but from an environmental standpoint, they're very different. Mm-hmm. I think that awareness alone can go a long way to promote the use of greener practices. Another thought is around health technology assessment, which serves as a basis for many recommendations, in many countries in terms of which products to use in the health system. And for the time being, there's very few instances where health technology assessment also looks at environmental impacts, but there's no reason that it cannot be integrated. And there's been already some examples where it's been integrated alongside the other typical consideration of health technology assessment.
Thank you so much, I think, both. Right. Questions are coming in here. Okay. Is there recycling of glass bottles for used vials, and how to decontaminate before recycling? This question is a little bit okay. So we move. If it's not clear, we can move to the next question. So,
Just to say, I'm not an expert on this specific question, so I wouldn't be able to
fine,
answer.
fine.
And I can just say one more thing. That definitely there are different ways to do it.
Yeah,
Pretty much. So I think it's a more hospital question. So I think
yes,
protocols, and there are a lot of kind of standard operating procedures in each country, and according to the regulations, and even each hospital, they sometimes have their own incinerator, or sometimes they have a third party incinerator. So I think it's a specific question. So what I would recommend in this point is just check in your country what are the standard procedures to do that, and in your region or the hospital. And if it is not there, then I think there definitely should be some guidance from WHO or even FIP. I'm sure they might have some resources about that. Also, our Canadian Society of Health, what they call it now, health information. They changed. I don't know. Everybody changed the hospital pharmacy to health systems, and I agree with the change, but I'm trying to get used to it. Health systems. Yeah. So hospital pharmacists would definitely give you a good impact on that.
thank you so much, Tarek. You. Moving on. No, this is quite. Um, is as active ingredient like artemisinin, is it affected by climate change? And can we look for semi-synthetic or synthetic modified substitutes that is more resistant? I think this is more of like pharmaceutical industry perspective. Yeah, but if you have anything to add to that, that's fine. But if not, we can move on to the next question.
I'm
I
happy
can,
to.
sure, go ahead, Vince. Let's start, and I can add
I
something.
can start, and you can complement, Tarek. No, it's actually been done. So to synthesize artemisinin from semi-synthetic input as opposed to a natural ingredient, but it's not done to scale at this point. So I think there's one facility in the world that can do it. The volumes are still small, and in terms of commercial competitiveness, I think there's been some challenges to make that a viable commercial solution so far.
Well,
Okay.
my point is, I think we have to step, as pharmacists, we are very too much involved in the chemistry and how to kind of find the right product for the patient. But I want you to step back and take a look from the bigger picture, even if it's synthetic or not synthetic. Like, I mean, definitely climate change will affect, because as Vince mentioned clearly, if there is a dry, like I'll tell you an example. We have pumpkins. Halloween season is coming. We have pumpkins. The farmers in Quebec, they found that pumpkins this year is 30% smaller because there was a very hot summer and very dry summer. There was not too much rain. Okay, so the climate change definitely will affect everything, even if you can see it or you cannot see it. It will happen. You can realize it later, but it will affect everything. And also, I spoke briefly, but Vince maybe spoke much more in detail about the supply chain itself. And even if you have a semi-synthetic or something, what about transportation? How this is going to definitely there will be an impact across the life cycle of the product. So look at the picture a little bit more from a higher level, rather than just switching from natural extraction to semi-synthetic or synthetic.
All right. Thank you so much for that answer. That's quite explicit. Okay. I think the last one here is how can deep prescribing work hand in hand with retail pharmacies, which are profiting from selling drugs in low and middle income countries?
That's a question for me, I guess.
Yeah,
So
it's for
I'm
you.
very privileged actually to be started working my master's on my master's degree with one of the world-renowned experts in deep prescribing, Dr. Lisa McCarthy in the University of Toronto. So the prescribing, I think it's something that has to be embedded in every single in our mindset. It's one of our tools. So the first thing is when we work in, you assess treatment appropriateness. Is this medication right? I'll give you an example. Benzodiazepines, the biggest the biggest kind of elephant in the room when we talk about deep prescribing, right? So many benzodiazepines have been prescribed, for example, when a patient is going for a procedure or went to the hospital for something, and they have to calm them down, and they are used in the hospital. But then when the patient is discharged, does the patient need to be on a benzodiazepine? Big question. So here is the pharmacist. It's a pharmacist's skill to assess the appropriateness of the medication or the treatment regimen in general. and make sure that this is the appropriate treatment for the appropriate case, for the appropriate condition, for the appropriate patient. So making sure that this is what I call the prescribing. And then if you decide this is not the right medication for this particular condition and this particular patient, then we have to deprescribe. And deprescribing, now you're getting into a more deep kind of clinical approach. So are we, like, I'll give you an example. Couple of times you might cut the dose into half, for example, and keep going. Sometimes you might switch to another alternative and then cut the dose into and start to decrease 10% every week or every 2 weeks. So there's so many different protocols, and it's different from per patient, per medication, per condition. But the whole concept as a pharmacist is to kind of keep deprescribing as one of your very favorite tools. When you see any patient, assess, is this treatment appropriate? Do I need to deprescribe or educate or switch or do what? So it's always a mindset, and I think this is how the best way to approach it.
Thank you so much, Tarek, for that. So someone is asking, how can we calculate carbon footprints in our respective areas? Do we have like a system, a toolkit that can be used? I know we have some online calculators and platforms where people can do that, but we have specific ones. You can share your case study from Canada, Tarek. You can chip into that as well.
You want to go, Vince, first?
I can start, sure. No, I'll start by saying that the methodology for calculating the carbon footprint of a product is called life cycle assessment, so LCA. It's quite a comprehensive methodology. So if you want to do like a good job using this methodology, you need to understand the full value chain of the product. You need to know all the ingredients, in detail. You need to understand all the steps of the chemistry. You need to know like how much energy is being used, where it's manufactured, what type of transportation, and so on. So it's quite a resource-intensive exercise. We've done it for a few products. And this is why, depending on what you want to use this information for, you may want to look at different alternatives. So the best is to look for databases, first of all, that may have already the LCA assessment of a wide range of products. And you can use that as a point of reference to know, is this treatment particularly carbon intensive, yes or no? You may find some of those databases, I think it's growing now, it's expanding, for active pharmaceutical ingredients as well. Because there's a wide variation of footprint between APIs. But I would say all of this is still in development. So I cannot point you, at least to my knowledge, there's no like one single source where you can find pretty much every molecule that you would have in your pharmacy with a proper LCA.
Thank you so much, Vincent. Do you want to add anything, Tarek?
Yeah, I agree with Vincent. There is a lot of it's a very tedious kind of process, and I think some of my colleagues at the Canadian Association of Pharmacy for the Environment were working on creating some similar kind of easier calculators or something. But I always like to shift the mindset to why do you want to do that? Like, even if you know that you have like whatever 1 gazillion tons of carbon, I think starting on action is good as well. Like, you can start by doing simple things. Like, I'll tell you as one simple thing. When you get an inhaler, like we have a recycling service, like companies who take the patients, like the take home medications, like or take back medications that we get from patients. We put it in a container, and a company comes and incinerates it properly. I know that at least 50% of the pharmacies, they don't remove the canister, like for the MDI, they don't remove the canister from the plastic. They throw the whole thing into that incinerator. But if you do that one simple thing, put the plastic in the recycling and put that the canister in the bucket that will be taken for incineration, you already saved a lot of carbon emissions, right? So I think what we need to start to think about is, I'm not going to do anything until I calculate the carbon footprint of what I'm doing, or versus I can start working on things, the things that I can do, reduce like change all your electricity to LED, have sensors to shut the electricity when you are not in the place, the water, make sure the water is not leaking anywhere, and all the system is done. Like, start with the basics of operations and procurement, making sure that, as we mentioned, like you buy bulk for the products that you use very much more. You control your inventory so you don't get a lot of expiries. Like when you start to do those things, it will start to get you into the mindset of being sustainable, and then you can build up on finding more and more. Because one of the examples I want to give, if we have a minute, is heparin. And I talked about this in details. If you want to go to the Canadian Pharmacists Association website and find the Seeing Through Green presentation that I gave last year. And life cycle assessment, as Vincent said, is the most accurate thing. But there are three different scopes. Scope 1 and 2 and 3. Scope 3 is the ones that you are not related to you. For example, in order to produce the quantity of raw heparin that we need for the world production, you need to use 2 billion pigs. Just figure that number in your mind for a second. 2 billion pigs. Now, if you go to a manufacturer and tell them, how can you account to that number into your kind of life cycle assessment? That's a very difficult. They can tell you about, okay, in the factory, I know how much carbon I'm emitting when I'm sending the trucks, when I'm doing this. But how can we account for that? Like there are some areas that are really very difficult, and that's back to Vincent's point about like there are so many research are doing going on that. Because again, the pig in this case is not used only for that; it's used for 300 different things. And one of them is the gut. We take the gut extract, and that's where we extract the heparin from. So it's a very typical example. And when you look at pharmaceutical companies, big ones, and you look at their sustainability premise, and you will find they say we're trying to reduce to be carbon zero by this, by this, by that. But and most of them will put a disclaimer saying we acknowledge that scope 3, which is not directly related to them, it's related to getting the raw material and the manufacturing itself is very difficult to assess and very difficult to control, and we're working on it, and that's part of it. So it gets you get in the mud a little bit. So just take yourself out of that and just start to focusing on what can I do today in order to be able to be more sustainable and reduce my carbon footprint.
Thank you so much, Tarek. Right. Okay. I think we are running out of time gradually, so we'll just move a little bit quickly. So next question: how can prescribing work hand in hand with retail pharmacies, which are profiting from selling drugs from in LM in low and middle income? I think we've answered this question actually. We've answered this question already. Okay. And then the next one: does in today's world, where we look for drug efficiency, is there some criteria to promote more greener alternative new generation drugs to match the efficacy? Vincent, do you want to go first?
Sure. I think this takes me back to the point around health technology assessment and how you can have a holistic assessment of new medicines, for instance, in light of their efficacy, safety, but also price, of course, but also green, carbon footprint or environmental footprint at large, and sustainability elements. And for now, I think this is something that is exceptionally done, but not clearly not mainstream. It's a question that is more a question, I guess, for the national level institutions that are managing, the guideline and recommendations in terms of product use, but a key consideration for sure.
Yeah, I take the point from Vince, and I agree about the HTA. We're working closely with CDA in Canada, which used to be CADIS. So now it's called this Canada Drug Agency, and we are trying to work on how can we include sustainability and resilience in HTA. But one point to this is you need, as Vince also mentioned, and I think Haley mentioned it in her presentation, we need to talk about this. We need to keep talking. We need to keep advocating, because I can tell you from all the work we've been doing in the inhalers, pharmaceutical companies are now doing research on a much greener propellants. Okay, and it's coming. Already a couple of the companies already approved. There are a couple of medications approved in Europe, coming to North America, and probably go everywhere, that has propellants that are as good in emissions as dry powder inhaler. Okay, so again, this is one thing. The whole concept of talking about switching from MDI to DPI is not that we don't want MDIs, because the technology and the device is needed, but we need greener options. And when you say, okay, we're going to switch you guys, they start to think about, okay, can we do something better? Can we come up with greener options? And I think the more we talk about it, the more we practice with a mindset of finding greener alternatives, the better. The pressure, it's a grassroots kind of action. It will put pressure up on the systems and on manufacturers and everything to kind of think about the same way we think and change the status quo.
Thank you very much. I think that will be the last question we have now. So I think I'll just give both of you, let's say, one minute for your closing remarks before we conclude. So Vincent, do you want to go?
Sure. First of all, to thank you all for the opportunity to be with you today. I'm very impressed by the number of people and the diversity of locations where you're based. I think Tarek has said it better than I can, but there's always something you can do wherever you sit, whatever your role is. There's always a place to start. It can be daunting, especially when you look at the absence of evidence, and I face that all the time. That there's limited data on like heat stability, on carbon footprints, and so on. But you can build the data, and you can also work and do simple things to start the journey on sustainability. So I guess mine is just an encouragement to get on a journey and accept that you may not have perfect information, but you can move forward nevertheless. Thank you.
Thank you so much, Vincent, for your contributions. Tarek?
I echo Vince and thank Feb and thank Shima for the excellent moderation and Robin and everybody here. But I just want to add to what I agree with everything, and I think what you should take Vincent kind of advice. But I would add one more thing. We have around 160 to 170 people in the room, which is impressive, as Vincent said. Why are you here? There's something. You came to this particular environmental sustainability session because you believe in something. So find what your why. Find why are you interested in this? Do you want to make the world a better place? Are you personally or somebody close to you affected by this? And create your own why, create your story, and use this as a motivator to start changing the world today. And change you don't need to do something huge. As Vincent said, and as I said several times, one single thing, one simple step. Find something to start with, and the ball will be rolling. And I'm really very motivated and encouraged by seeing all of you here today, and that keeps me going, I guess. And thanks for having me.
Thank you so much, Tarek. That was quite a powerful closing remark and powerful, mind-blowing questions. Thank you so much to you both. Right. Wrap up and conclusions. Next slide, please, Ruben. Okay, yeah, so thank you so much once again to everybody that attended this our session. So you can also check out all upcoming FIP digital events on this link here, events.fip.org, whereby you'll be able to register in advance to attend our wonderful upcoming events. Right. Also to mention that our next conference, we just finished our 83rd World Congress in Copenhagen early this month rather. So just to let you know that our 84th FIP Congress will be held in Canada, Montreal, from the 30th to 2nd. Vince is raising his hand. Yeah, they will be. So yeah, if you want to come and see Vince in person, that will really be an opportunity for you to see. Sorry, not Vince, sorry, Tarek. Sorry, I missed it up. Yeah, Tarek, if you want to see Tarek, connect with him, please try to register to attend. So the title of our session is for our Congress next year will be One Health, One Pharmacy, Bridging Science, Practice, and Education. So for more information, look at the QR code, the barcode down here. You can scan that and get more information and in terms of how you can register and all. Then a little more details about the Congress. So we have 3 different sub-teams. The first one, integrated health, pharmacy advancing well-being through a One Health approach. Sub-team 2, innovation with purpose, driving change through science, education, and practice. Then sub-team 3, collaborating for equity, strengthening global impact through partnerships and inclusions. And then we'll have some important dates and timeline for you here. So for those of us that are interested to come, so know that the abstract portal is open. So be aware that on the 18th of March 2026 is the timeline to submit your abstract to be considered for next year's Congress. And then the outcomes. You will know whether you are successful or not by the 17th of April 2026. Then early registration fee deadline. So, for example, now we are talking about Canada. So, of course, there are some early birds timeline, and of course, those who will register late. So, for early birds, the deadline is make sure you register by the 3rd of June 2026. And then the second registration after the early bird closes on the 3rd will be 12th August 2026. So please note these deadlines. They're quite important. So thank you very much for attending, everyone. Thank you to Tarek, Haley, and Vincent for your wonderful presentation. And thank you to Ruben. And like you mentioned earlier, feel free to give us feedback, comments in terms of how we can improve. And we look forward to seeing you again. So thank you so much. Enjoy your day, your night, and the rest of your day.